So after talking about the tumors of the nasopharynx, in which we talked about the benign tumors, malignant tumors of the nasopharynx, how they present, how they are diagnosed and treated. Now let's move to the tumors of the oropharynx. And these tumors of the oropharynx, again, they can be the benign tumors of the oropharynx. Also, they can be the malignant tumors of the oropharynx. And then the TNM classification of the malignant tumors based on the tumor node metastasis, how severe they can be, and what's the staging of these oropharynx tumors. So let's begin with the section. First, the benign tumors of the oropharynx. Here, if you see, and if you ask the patient to open the mouth and press the tongue down, and this is the tumor, you can see very easily in the oropharyngeal cavity here. So that's the location of the oropharyngeal tumor. So benign tumors of the oropharynx can be papilloma. Papillomas like polyp can be pedunculated, means they have a stalk attached to them. Papillomas are pedunculated. They arise from the tonsil, soft palate, or pharyngeal parrots. When large, cause local irritation in the throat. Treatment is surgical excision. So papilloma, they are pedunculated, benign. So they produce the signs and symptoms or features which are more or less localized. So they cause irritation in the throat, pain in the throat, and the treatment is by surgical excision of the papilloma. Then hemangiomas. Hemangiomas, they develop from again palate, tonsil, posterior and lateral pharyngeal wall. They can be capillary hemangiomas or cavernous type of hemangioma. Treated only if increasing its size or giving symptoms, if it is causing problem or if it is enlarging, and then it can cause different symptoms like obstruction or blockage, then we should treat it. Treatment is by diathermy, coagulation, or injection of sclerosing agent, cryotherapy, or laser coagulation. Hemangiomas are treated by the diathermy, laser therapy, cryotherapy, or injection of sclerosing agents. So these are the two benign tumors. Papilloma is one, and then there is hemangioma, which can be cavernous or the capillary hemangioma. The other benign tumor is pleomorphic adenoma. Pleomorphic adenoma, that's the histological picture. Adenomas develop from the glandular tissue, adenoma. Seen submucosally on hard or soft palate, potentially malignant, excised totally. So this pleomorphic adenomas, they are potentially malignant. They have ability or they can convert into malignant type, and they can metastasize to the distant sites. So they can also be excised totally. Mucocyst, another benign tumor seen in vallicula, yellow in appearance, pedunculated or sessile. Treatment is surgical excision if pedunculated, or incision and drainage with removal of its cyst wall. Cysts are the sac filled with fluid. So if cysts are present, usually the drainage is recommended also. Drainage is performed, and then removal of the cyst wall is done. They can be sessile or pedunculated, no stalk, with stalk. So pleomorphic adenoma and mucous cyst, they are also the benign tumors of the oropharynx. Malignant tumors of the oropharynx, they are superficially spreading. They spread superficially without infiltrating or invading deep. Exophytic type, ulcerative type, and infiltrated type. So superficially spreading, they spread superficially. They might be exophytic, grow out, or ulcerative or infiltrative type. These are the different types of the malignant tumors of the oropharynx. Histologically, when seen under the microscope, the different types of malignant tumors of the oropharynx can be squamous cell carcinoma, lymphoepithelioma, adenocarcinoma, and lymphomas. All these are different subclassifications or classifications of the malignant tumor of oropharynx when they are examined under the microscope. When the tissues are examined under the microscope, they can be squamous cell, lymphoepithelioma, adenocarcinoma, lymphomas, depending on the site of origin of these malignancies. TNM classification of these malignancies. TX, no available information on primary tumor. Nothing is information, no information is available whatsoever is the primary site of the origin of the tumor. TO, no evidence of primary tumor. TIS is the carcinoma in situ. T1 less than 2 cm, T2 2 to 4 cm, T3 more than 4, T4 more than 4 cm involvement of the natrum, pterygoid muscle, base of the tongue or skin. Then metastasite MX, not assist, MO, no evidence of metastasis, and M1 distant metastasis is present. As far as nodal involvement and part of the TNM classification, NX cannot be assessed, and O, no clinical positive node involvement, and 1 single ipsilateral less than 3 cm, and 2A, single ipsilateral 3 to 4 cm, 2B, multiple ipsilateral less than 6 cm, and 3A, single multiple ipsilateral one more node more than 6 cm, 3B is bilateral, 3C is contralateral. All depending on the involvement of the lymph nodes, what's the size of the lymph nodes after involvement, how big they are, whether they are bilateral, ipsilateral or contralateral. That is our TNM classification depending on the tumor, node and metastasis. So that was all about the section 4 in which we talk about the tumors of the oropharynx. Thank you for watching sqadia.com.